Uh, Ladies and gentlemen, if we can take our seats, please. Everyone down the front, fill the front from the back. Yes. Dr. Duke. We just please, can you hear me? Can you hear me? I got to be very careful because I'm on YouTube at the moment, so I've got to be very careful and very polite. So, Dr. Duke, Professor Ross, if you don't mind finding a seat. YouTube. None of that other tube stuff. Ladies and gentlemen, can I please welcome you to Gambaro's tonight for our Equinox user meeting. Unfortunately, we had a little AV issue because of my love of music and my love of Powderfinger. We were playing Powderfinger through YouTube, and we apparently breached copyright. So my apologies for us running a little bit late. Can I please welcome our special guest here tonight, Dr. Steve Fredrickson, who's going to talk to us a little bit later. Dr. Terry Hammond from Pindara, who's going to talk to us a little bit later. But one of our international speaker here tonight, we're going to at 7:50, so I'm a little bit beyond time. Dr. Moby Parsons will join us via some way of the World Wide Web, and hopefully we can get that through seamlessly, and we're not playing Powderfinger to breach copyright. But appreciate your time. Please enjoy your evening. We're joining here, we're via YouTube to WA. The folks, I'd like to welcome them from WA due to their lock-in and also the fires over there. And can I also welcome via whatever we're doing here tonight, YouTube, Mr. Christian Plaus, who's the Asia Pac sales manager for Exactech as well. He's joining us via Sydney as well. So we've got about 50 participants here tonight across both mediums, sitting here enjoying our good food and good wine, and also sitting at home enjoying baked beans and cask wine. So please enjoy. Can I introduce, please, Sasha Laws, one of our partners here at Medi Solutions for the Upper Limb area, to do a little bit more of a formal thank you. But thank you very much for your time tonight. Thank you.
Hello, so we'll try and catch up some time. Just to give you a rundown, I suppose what we're doing tonight is actually on your tables if you want to have a look at the proceedings. First of all, we'll get Steve Fredrickson up, who's going to give us a little bit of an insight into how he started using Equinox briefly, and then talking about tips and tricks. Most of the people in the room have seen navigation or used it. For those guys who haven't, Steve will sort of show some things that are probably things you can use when you're in surgery to make the procedure a little bit more seamless. Then he'll talk about glenoid augments, which is a topic that I suppose in previous years it was all about bio-RSA and bone blocking and those sorts of things. And now with augments, most companies have got augments now, so Steve will give an insight into that. Terry Hammond has been looking at every possible infection paper on the planet to give us an insight into what the latest things are on C. acnes and revision surgery based on C. acnes. So that'll be an interesting talk. And then we'll log into Moby Parsons, who will give us an insight into a little bit of a biomechanical talk about reverse shoulder, and then go into the technology that's coming, which is now artificial intelligence is sort of making its imprint in surgery of the shoulder. There's some social media options for surgeons now to share a patient care throughout the world, which he'll talk about. And then if we've got time, there's a couple of surgeons who've got some cases that might want sort of an opinion through the room. So we'll get underway with Steve. If there's any questions, we'll do that at the end of the talks. We'll hand the mic around and you can ask some questions, but we'll sort of move on. So thanks for coming. Good turnout on a Wednesday. Sorry for the delay, and we'll keep going. Cheers.
Am I going fast, Sash? So talk about the experience stuff? Thanks, Sash. Sash this afternoon asked me to just add in a little bit of my experience first in the transition. Some of you may have heard some of this discussion before, but A couple of years ago, I was a Delta user and just noticed that cosmetically I wasn't happy with that sort of drawn appearance to the shoulder, in particular with the thin people. And I'd had in the older population the occasional acromial stress fracture, and I was looking for what I thought something biomechanically was a bit better. So transitioned and went to San Diego and did the cadaver lab over there, and then looked to move across. And I had a little bit of a hiatus with a wrist injury, but then transitioned after that. My wrist still works, thanks, Mark. I've been happy with that transition, particularly with the navigation and pre-planning things. And I was surprised to hear that the US population, because they weren't able to use the navigation, weren't using the planning software. And I think the planning software itself is part of the real advantage. Am I starting this myself?
No, I thought I'd start that for you. Sorry, Steve.
That's right. Is that it?
Yeah, that's it.
Oh, that's Terry's. With regards to this talk, I'll keep it quite brief and consigned to tips for acquisition and also when I choose augments. And I've become quite conservative in my use of augments. So with regards to tips for acquisition, certainly it needs to be fast, though I'm not. That component is reasonably brisk. Accurate, easy and reproducible, and then above all safe. And I think that's the main thing for us is the safety of the navigation process. And there's a lot of checking and double checking just to check to make sure that what we have planned is being reproduced on table. So the planning starts in the preoperative phase, and if I've got a tight shoulder or a retroverted shoulder, retroverted glenoid, I'll modify things a little bit, and I'll be a bit more aggressive in the incision size, the humeral head osteotomy, and releases to enable access to the glenoid. So it's all about access. I think this is a real advantage of the planning and navigation is really thinking about access. Within theatre, my apologies not for no photo, but having the camera positioned and drapes taped out of the way so that we've got clear communication with the tracking post. I don't adjust the head, but I make sure everything is visualised around it, and to preempt the problems. Certainly vision of the camera. We've had an early case fail with some camera vision problems, some smudging. Loosening of the tracker post and double checking throughout the case with that. And then just making sure clear access when acquiring and during the navigation process, and having an assistant that has some experience or at least has been briefed on what we need to do during the case. So the incision doesn't need to be huge. I don't go that far north of the coracoid. I work sort of up and under the skin and soft tissues to fix the tracker post. So it's reasonable that a standard sort of shoulder incision is appropriate, but that's increased if we need the access. Early expose the coracoid and release the medial and lateral structures of the coracoid. So just planning early for that tracker post, and enabling that sort of a decent solid position for the tracker post. Deliver the humeral head, sorry, that's the view, and deliver the humeral head and osteotomise appropriately. And then I know some individuals will use a K-wire and use the posterior hole first for placing the tracker post and sort of centre in the coracoid. I haven't had that issue. I loosely place the anterior screw and tap the screw in, and then place the posterior screw, tighten it down to the coracoid base, and then come back and tighten the anterior screw. Bit of a shake there, but it's at this point that if the bone quality at the coracoid is not reasonable, I'll place a crab claw across that. Really safe in that. So just clamping a crab claw, and that crab claw's out of the way. It's out of the way of the operation, and it just firms up the hold on the tracker post if required. And so that's the sort of access that I like to see. And my apologies, it's a photo of it after I've started reaming too. But that's the sort of access that I like to see. Making sure that soft tissue and cartilage is cleared from the glenoid, just to enable the acquisition next. So the acquisition process itself, and this is real time, so it pays to have an assistant that is experienced, and they can call the process so that you don't actually have to look at the screen. You can just be concentrating on the acquisition and really working through. So medial lateral coracoid, basic coracoid, superior, inferior, anterior, posterior, posterior, and then knowing where your landmarks are, including the lateral column, so that you're not guessing at the time. Coming across the anterior, you've painted the face, anterior neck, and then posterior. And the whole process doesn't need to take that long. So this video is 45 seconds, and that's all you need. You don't need more than a couple of minutes. It's all about the exposure and just preempting any problems. And then double checking your positioning. So always then just taking your acquisition tool and making sure that what you've done matches what you see on the screen. Sorry. So then finalise post-acquisition. Reassess at each point. The entry point itself, the literature supports within 3 millimetres, and I will always try and find my entry point without looking at the screen, just so that in my head, I've got the plan, and I want to know exactly where I think it should be, and then I'll check and make sure the nav matches or matches within the region. I'll do that with the version as well and inclination, and you can see that a resection of the glenoid should match your plan, and if it doesn't, stop and reassess. Don't always blindly follow the navigation. And then always just checking and double checking the tracker post and making sure that's secure. With regards to reaming also, it doesn't hurt early to rock the reamer a little just to progress along, particularly if you're reaming a decent amount of glenoid. So with regards to augmentation, the literature would suggest an increase in augmentation use with computer-assisted surgery and a bit over double. Certainly in the first half of my practice here, and this is since my wrist injury with the reverses, the first half of the planning was on CT only, not having planning software on my computer, which I do have now. And I would plan and then come in and we'd redo it on the software. And it would be often that I'd change to an augment. And it wasn't so much the retroversion that would catch me, it was the inclination that would catch me. So just being a little bit more aware of the inclination. But certainly I'm a little bit more conservative nowadays, and if I can use the standard base plate, I will, but I still about a third of mine are augments. When I choose augments, or when do I choose augments, the aim is to achieve parameters in version, inclination and overhang, to preserve bone stock and achieve acceptable vault position of the central component and screws and get acceptable glenoid coverage. The augments will lateralise the glenoid, and we know that there's improvements in range of motion and joint stability from the literature, though I'm wary of tightening up the shoulders, particularly the older, thinner ladies who may not like increased deltoid tension. And so I'm wary of tightening them up a touch. And that's where the conservative nature of the coming back to the standard base plate is. The literature would suggest the acceptable is neutral to 10 degrees of retroversion, 0 to inferior tilt, and some overhang. The older literature would certainly say that that increased inferior tilt, that was with a Grammont style, so 155, and that sort of the glenosphere looking down more at that 155 humerus compared to the 145 on this prosthesis and others. Is Dr. Parsons talking about humeral version and humeral anatomy? Yeah. And so the interesting thing for me is we don't assess the natural humoral version in each patient to match this, and I think that's coming. So that's what we've been told is acceptable, but then we add in real life, and real life is patient factors of age, comorbidity, expectations, function, and what may be acceptable in a lower demand patient, and also with bone quality and working around what we've got to work with in the glenoid. With regards to surgery factors then, we aim to achieve adequate vault fixation of the central component, and adding in then increased screw length with navigation, improved fixation, the screw locking, and then whether or not screw penetration of the opposite cortex adds strength to that as well. So those improved factors in fixation, which may add additional strength in the construct, and then with augments as well, and the biomechanical effects of having the augments on the glenoid. So we know that with navigation there's improved, this is one of Mark Haber's papers, the improved screw length. I'm surprised about the superior and inferior screws, and certainly with this navigation process, my superior and inferior screw lengths have increased by about 30%. I try and decrease my incidence of cage perforation and get a good vault position of the cage, although occasionally I don't hesitate to perforate if required. With regards to mechanics, within the parameters that we've talked about, there's a wide range of positions within the vault that we can place that central component and screws. If you see the difference there, so that's 7 degrees there, and that gives us a broad range to play with, to preserve bone, to use our augments to achieve acceptable fixation and a strong construct. All of our parameters have been developed through anatomical prosthesis and then lab reverse base plates, and such that the biomechanics are different in this scenario. So different forces, different shear forces, and different contributions of an imbalanced cuff and muscle forces. So this is a complex biomechanical scenario not yet outlined. So if we then take that glenoid and scroll through and plan, we achieve at least there's about 68% coverage there, and an acceptable vault position. I actually was planning to graft the back and did so, and screwing that into place. But we can see, slight retroversion there, acceptable vault position, and plenty of room for the screws. And on plan as well. I find the good thing about the navigation process and planning, it just reinforces sort of the odd surprise that you may not take as much notice of. And I've had a couple of cases with this prominence at the lateral column, which has been excised at the time of surgery. So it just adds to additional information. So for glenoid implant choice, I choose augments on significant version. I haven't yet flipped a prosthesis and used the contralateral side for an antiverted glenoid, but significant version issues, superior glenoid tilt. I still try and use a standard base plate within the parameters, but it's a case-by-case basis. We aim to achieve acceptable vault fixation, including screw fixation, and minimise the bone resection. And watching, of course, for the centre rotation, and I'm just come back a little bit on how aggressive I am with the use of augments with that. So if we come to that case, that retroverted case, oh no! I assure you, he's got a great range of motion. Something there, it didn't work. That's a shame. So if we move on, oh, hold on. So he was about just over 40 degrees of retroversion there with some subscap and biceps disease. So a couple of quick cases there. So this is B3 glenoid, and again, quite easy to achieve coverage, but we could use a standard base plate or an augmented one, and depending on how much bone you resection. I tried to not resect too much bone there, but again, achieving acceptable vault fixation, and then planning for screw position as well. Here's a case that would normally or would have caught me out without the planning software, and that's retroverted glenoid with a reasonable amount of superior inclination. In this case, I've accepted 4 degrees superiorly because we've got strong fixation, including screw fixation, and the posterior superior augment, the vault fixation. We had a little bit of penetration there. It wasn't quite as good of track for the central component, so we've gone with a superior augment. And with the glenosphere, that 4 degrees really is minimal. And what we want to avoid, or what I try to avoid there, is my last Delta case, and that was by RSA, and he's doing wonderfully well, and he's very happy, but I'm just a little bit concerned about what's going to happen in the future. So I try to avoid that. Thank you.
Any questions for Steve at all about, I suppose, exposure or the navigation process or anything like that? From working in the field with you guys, I suppose as reps, you sort of try and figure out little things that can improve navigation and make it easier for the surgeons to get their acquisitions and those sorts of things. And I suppose the one thing that I've noticed is that we've started to put the navigation computer, which sits on the contralateral side next to the arm board, we've started to push it a little bit more laterally. So distally towards the end of the bed, we probably move it about another 20 centimetres, and that seems to give the tracker a little bit more visibility. The other thing too to consider if you're a Spider user and a T-Max user is the scapular board that you sort of leave free so you can move the arm around. When you're actually going to do the acquisitions, if you push that scapular board across and sort of stabilise the scapula as you're retracting posteriorly, that stability of that scapular board stops the tracker post from moving with the retractor. So that sort of keeps the tracking post, I suppose, in view. So that's something to consider. The other thing that a couple of surgeons that I work with have done too is when you're handing off your lavage and your diathermy, typically you guys throw it down the bed. So I've got a few surgeons now that wrap it around the patient's head and have the diathermy and the suction at the top of the head, so it actually pushes the drapes flatter across the patient's head, and then that obviously clears the line of sight for the patients as well. So they're two little tips in relation to navigating, so you can sort of make sure that the systems are communicating well. Steve, if you could name 3 things in relation to your exposure that help you navigate quickly and easily without complication, what would they be?
Certainly, coracoid exposure and acceptable fixation of the tracking posts, and then really concentrating on my glenoid exposure and soft tissue clearance. I'm a little bit more aggressive inferiorly now, obviously just identifying, protecting the axillary nerve throughout, but getting quite aggressive with that glenoid exposure, as you've seen there, so that by the time you come to do the acquisition, it's really all there, and that's why that component can be quick, because the work was done prior.
What about your humeral cut? Have you adjusted anything since you've gone from a Grammont principal implant to an onlay system at all?
I'm reasonably aggressive with the cart, but as you've seen, I've probably then ream again further later on. So I think I could be probably more aggressive again.
In relation to the augments, I've done a couple of cases recently in those arthritic sort of cohort where it's not so much an arthropathy, it's more an arthritis case, and they're hugely tight, hugely retroverted. And one thing I've noticed when surgeons sort of go to work to do their, I suppose, their reaming or their central post positioning. It's very difficult to push the humeral head as far as maybe it is in other sort of situations. And one thing I've sort of known, that bone is typically hugely sclerotic. A couple of surgeons now have got a burr on hand now where we ream, I suppose, the anterior side of the glenoid to allow you to sort of level the glenoid out so you can get your reamers in, and then it's not so much of a fight against the humeral head. So if you've got a hugely retroverted glenoid that's arthritic and they're a tight, I suppose they're tight naturally, then maybe have a 4mm burr on hand when you're using augments particularly. That's one thing that sort of in combination saves you guys. I mean, there's nothing worse when you're a rep seeing a surgeon sitting on reamers and they're blowing up about, are your reamers sharp enough? And we sort of start to cringe when we get that comment, because that happens a lot. But in combination with a burr, then it'll fast track the process quickly. So if you find those patients, then that's something to consider to have in the room when you're doing them, particularly if you're going to augment as well. So thank you. Any other questions, or we're right? I think we've made up some time there. So we'll let you eat and then we'll get Terry up to talk about infection. Thank you. Well, he was supposed to come in.
It's that Wednesday one there, yeah. That's the one. Among other things, yeah, among others.
Are you going into things outside after the plastic?
No, not really, but it does actually. Yes, I am actually. In
Like
fact,
anchors and all that? Or
no. But it does actually fit with that anyway. So, yeah, yeah.
Hello. Okay, everybody, we're going to get back into it. Terry's going to give his talk now on infection and the latest literature that he's looked at. Thank you, Terry.
Okay. Well, thanks everyone. Thanks for coming tonight. And Sasha sort of sold me a bit of a dummy. He said, "Oh, there'll be a couple of people there. We'll just have a little round table chat." And didn't sort of realise it was going to be like this. He's asked me to talk a little bit about infected shoulder replacements. Is that coming up on the slide there? Can we make that come up? Can we have a little bit of AV help, please? Oh, there it is. Okay, lovely, fine, fantastic. So if we're talking about, hang on, I'll go back here. Okay. This talk was originally going to be a pretty sort of standard talk about diagnosis, prevention and management of infections. But in doing some reading for this talk, I've come across quite a lot of papers recently that have challenged a little bit about how we think about infections. Hopefully I'll be able to present some of that tonight, just for food for thought, if nothing else. So if we talking about infections, obviously the first thing we think about is C. acnes, but I think this talk also applies to some of the more indolent organisms like the coag neg staph, like Staph epidermidis. And we know that C. acnes is the commonest cause of periprosthetic infections. More than 50% in my experience, it's even greater than that, sort of 80 or 90% seem to be C. acnes. And very importantly, we also think that it's a common cause of unexplained problems in shoulders in general, so pain, stiffness and early loosening and even rotator cuff problems. So we sort of say this, hear this bandied around, that if it's a problem, it's C. acnes infection till proven otherwise. And perhaps we need to just step back a little bit and wonder if that's actually true. So conventional wisdom tells us that C. acnes is a very indolent infection, and so it's very difficult to diagnose. There's no real clinical signs of infection, normal CRP and ESR, and a negative aspiration often. So that means that our diagnosis is hugely dependent and often completely dependent on tissue cultures. And so what we do is we have a person with a painful shoulder we think could be infected. We go and we take cultures very cleanly as we can. We get a couple of positive culture results and we say it's a C. acnes infection and treat it from there. But obviously we're committing patients sometimes to major surgery, multi-stage revisions. So we definitely don't want to have false positives. They are a big, big, big problem. So what is our rate of false positives? Well, I think we do have an understanding of that based on some of the studies that look at the rate of positive C. acnes cultures in primary shoulder replacements. And we know that's reported as big range, but between 3 and 73%, but importantly, averaging around 38%, which is a huge number. So 38% of primary shoulders, which we definitely do not think are infected, I'm sure we'd all agree, have positive cultures. And so that's really the dilemma. In a primary shoulder replacement, diagnosis with positive cultures is certainly not infection, but when we get it in other situations, we diagnose infection and we say it's probably due to that organism that we cultured. So I think that's definitely a little bit of an issue. Now, a lot of people have taken a bit of solace in this paper here, the one from Royal North Shore. It's been reported as only a 3% rate of 2 or more cultures positive for C. acnes, but that's one of the very, very few papers that have had such a low rate. So I think it's worth looking at a bit. It is worth noting that they did give antibiotics preoperatively, which possibly we wouldn't do, and perhaps that does have an effect. They did have a very strict collection and processing protocols, and the reality is that we may, in our clinical practice, given the fact we don't do this all the time, hopefully not very often, we may find it difficult to do it as cleanly as they did. And what's important is not what they can do, but what we can do in our practice. And if you look at the paper, they actually had 4 out of their 32 specimens did actually have at least 1 positive culture. So their rate of 1 positive culture or more was, in fact, 12%. And their subsequent paper, the same group there, did actually find very high rates of positive cultures from things like the dermis and the tip of the glove. So I think maybe we still need to kind of consider that rate of 38% as being maybe something that we have to consider. Certainly, I think to consider it as a 3% perhaps might be a little bit wrong. So if we do consider that that's a high rate, where does this come from? And obviously our first thought is that we incise through the sebaceous glands and hair follicles and we release C. acnes into the wound. And hence our management like washouts and change of gloves and using benzoyl peroxide. But is that the only explanation? Perhaps it isn't. So we know there's likely also to be contamination potentially from outside the body, from air, from the laboratory. I mean, the ironic thing is we actually purposely now create an environment to grow C. acnes. We tell the laboratory to grow it for 2 weeks. We put it in anaerobic and aerobic cultures. We look at the broth as well as the primary plate. So we're almost creating a situation where we're bound to grow C. acnes. So no wonder we do. Worryingly, studies like this that showed that 13% of just their sterile sponges grew C. acnes. So that's obviously something outside the wound. So contamination is a potential issue. C. acnes, there's a recent paper, in fact, this month in Journal of Shoulder and Elbow Surgery that wondered whether C. acnes is actually commensal, something that lives in the shoulder normally. I mean, we've addressed this, thought about this many times, but this paper here found C. acnes in prostate, lung and spinal discs. It survives apparently in macrophages, and when they looked at the phenotype, the superficial tissue phenotype was different to the deep tissue. And so perhaps it's a different organism that lives deeply, and that's the one that we culture. And perhaps it's an innocent bystander, not actually a pathogen. Obviously, a lot more work is needed to be done in this area. And then, is it a significant pathogen? I mean, after all, if we believe our cultures of 38% in primary shoulders, but we only get a rate of infection of 1 to 2%, you know, where's the logic in that? Could there be undiscovered organisms causing infections? Maybe we pick up C. acnes, but there are other organisms. So these guys did a next generation sequencing, which is a technique looking at DNA to try and identify bacteria without actually using cultures. And they found when they looked at 44 revisions, when they cultured it, they pretty much only, and I know you can't read this, but pretty much only grew C. acnes and occasionally Staph epidermidis. But when they looked at next generation sequencing, they grew a huge number of organisms, and I stopped counting at 30 there. So in 44 cases, they have over 30 different organisms found. And this paper here also agreed with that, with cultures only finding polymicrobial in a small number, but when they did next generation sequencing, found it in the majority of cases. So where does that really leave us? Well, what it probably means is that we have to have a few thoughts about how we go with cultures. So positive cultures do not necessarily mean that that organism really is present. It could be a contamination from elsewhere. Even if it is there, it may not be the organism that's the source of the infection. It may not be as pathogenic as we think, and there may be other organisms. And I think really critically, it also means that if we do a culture in something like a painful, stiff, loose shoulder or a rotator cuff repair, if we find a positive culture, we have to accept the fact that it might not necessarily mean there's an infection there at all. We definitely know we're very certain it's positive. It's true in primary arthroplasty, so possibly true in these other cases. And is a diagnosis of infection in these situations sort of like a self-fulfilling prophecy? We think everything that's got a problem is infected, so we biopsy it. We have a high rate of false positives, so that just reinforces our idea that everything is infected until proven otherwise. So there is a bit of an issue there potentially. So I'd like to switch now and talk about management of infected shoulder replacement. And I must admit I'm a bit embarrassed to talk about this because I'm sitting in a room full of many people here who've got a lot more experience than I have. So please take some of this just as thoughts rather than absolute dogma of how you should do it. So if we think about how we traditionally manage an infection, this is how we're taught, and that is to confirm the infection, identify the organism, and then remove the prosthesis. Then we treat the infection. We then confirm complete eradication of the infection, and obviously that's a vital step, and then we reimplant the definitive prosthesis. But as you can see, cultures in shoulders are the big part of these two steps of the prosthesis. We don't have all those other things that the hip and knee guys have, like aspirate and CRP and ESR. We have to rely on cultures. So if cultures aren't reliable, then perhaps this whole process, excuse me, can be called into question a little bit. So what are the results of some of the different treatments of infections? So this is a paper from Mercioli from 2017, and very interestingly, there was one just last year or a couple of years ago that almost identically agreed with these numbers. So these numbers are pretty universal over most of the studies that look at this. So the chart's a bit complicated, but it's the different techniques on the left, the number of studies and the number of patients there in the middle columns. And you can see we're not talking about huge numbers by any means at all. And the results of persistent infections, so in other words, failures on the right there. So if we look at debridement and retention, not great chance of eliminating the infection, particularly in the chronic case. I'm sure we'd all give it a go in the acute, very early phase, but chronically doesn't work so well. Resection surprisingly doesn't give us perfect resolution of infection, and of course very poor function and poor patient satisfaction, so a bit of a salvage only, I think. And this is a really important figure, and I'll come back to this in a minute, but putting in a spacer with, in some studies, and without, in some studies, continued antibiotics actually gives pretty good results. And that's interesting because, of course, after a few months, the spacer stops eluting antibiotics. So it's basically a foreign bodies, but they do have good results in terms of eradicating infections. Similarly, one stage, oh, by the way, one of the big things I wanted to raise is that, in general, with a spacer, poor patient function and satisfaction, so ongoing pain, poor function, and presumably that's because most spacers are loose in the humerus, so they just rattle around. And also, we've often got a non-spherical humeral head articulating with the glenoid, and obviously cement is a pretty awful substance to articulate with the glenoid. So that's probably why they have poor patient function and satisfaction. So interestingly, a one-stage revision, again, good results and universally reported as pretty good results in terms of function, patient satisfaction and eradication of infection. And sort of worryingly, two-stage, which of course is sort of the gold standard in hip and knees, doesn't eradicate infection as often as we'd possibly like. So if we look at these results and some of the other things I talked about, I think a really interesting thing comes out. First of all, we know that positive cultures in primaries in a large number of cases, but the infection rate's only 1 to 2%. So we're, theoretically at least, implanting a prosthesis in a contaminated field and yet getting good results. And in one-stage revision, we are definitely, by definition, implanting a prosthesis not only in a contaminated area, but in fact an infected area. And the same with long-term spacers. Once again, we're implanting a component in an infected area, but getting good results. So the question is that perhaps achieving and confirming a culture-negative environment is not always needed to produce a satisfactory outcome. And perhaps it's because, as I said before, some of the steps of our ideal process here fall down a little bit in shoulders. And so it's not so much that this isn't a good thought, because I'm sure it is, but our practical ability to put this into place in shoulders is less than perfect. If we go back to saying, well, no, we really want to make sure we eradicate infection before we put it in, then two-stage is what we would normally do, but the rates aren't great in terms of eradicate infection. So then we may need to go to a three-stage. And this is one of the protocols that has been talked about for a three-stage. And you know, strap yourselves in because it's a big job. So stage 1, spacer debride biopsy, 6 weeks of antibiotics, 2 weeks off antibiotics, new spacer debride biopsy, and then wait without antibiotics for 2 weeks and see what you get on cultures. And then, if negative culture, implant, positive culture, repeat the process again. Go through the whole thing, 6 weeks of antibiotic, 2 weeks off, and then new spacer. And I mean, obviously, that is a big deal to do. I mean, advantages, of course, is that we're confirming to that firm principle that we all like to stick to, which says, don't in any circumstance implant a prosthesis in an infected area. And hopefully it can eradicate the infection, but gee, there's some significant disadvantages, isn't there? I mean, it's a very prolonged process, it's expensive, potentially high morbidity, although certainly less than in the lower limb guys. Repeated soft tissue insults, which can't be a good thing. Prolonged IV antibiotics in multi-stages, which again has got some problems. And long periods with a potentially painful, poor functioning spacer in, and perhaps unhappy patients during that time, and a lot of angst for surgeon and patient. Hugely dependent on cultures, as we've said. So if you get your initial culture wrong, if it's a false positive, this whole process is sort of null and void, you know, particularly if the diagnosis was an infection in the first place. And false positives during these stages obviously potentially prolong the management. May be inevitable, but obviously it's not a good thing at all. And you've still got the problem of a new infection. So even when you eradicate every little bit of infection, when you put a new prosthesis in, there surely is a rate of a new infection. So we're never going to get 100% success with anything we do. So after all of this, what is a possible strategy for revising an infected prosthesis? And, I really like to emphasise, as I said, this is, have to be taken with a bit of grain of salt and subject to change at any time, because there definitely are some more evolving things that might change our opinion, but perhaps this just gives a little bit of an idea. So a one-stage revision really does seem like a great idea, certainly when you look at literature, but I think you really do need an optimal situation. So you need a good patient, not diabetic, not immunocompromised, good soft tissue. And rifampicin is something that we haven't looked at so much, but rifampicin is obviously active against biofilm, so if you can use it at 2 weeks when you need to start it, then obviously it's a good situation and may be very helpful in a one stage. But a lot of patients unfortunately can't tolerate it. We need ideally an organism established pre-op, highly susceptible to antibiotics, and an appropriate antibiotic, an organism that we can use antibiotics in the cement. And surgical technique, meticulous debridement, antibiotic cement. And I think this is a really important step that perhaps isn't talked a lot about in papers, and that is that we're really relying here on trying to decrease the bacterial load. So if you just take out the prosthesis and then just move immediately on to your next stage, then you've got a whole contaminated field. So surely it's a good idea to completely close up, maybe even put some betadine packs in, go to the tea room, get the girls to completely re-scrub, re-prep, re-drape, basically start from scratch. Surely that has to be a good idea in terms of putting in the definitive implant, but obviously with a longer time and a cost involved there. But not many patients fit the bill. So if they don't fit that bill, then what do? Well, we can do a 3-stage revision, as we've said, and perhaps we need to do that when it's a difficult to treat organism, when we need an allograft or expensive prosthesis, and there may be other patient factors that lead us to think a 3-stage revision is definitely needed. But what about all the other people, So this is sort of where Sasha asked me to talk. We're finally getting there, Sasha, about what the perhaps a little interesting thing is, and that is to consider a functional spacer. So this is from a paper from Jonathan Levy, who I think works with Mark Frankel. And this is from June 2015, and it's what he describes as a functional spacer. So the idea is to get a small hemiarthroplastic component, cover it with cement, but leave the head exposed. And then you put a big bulk of cement proximally. So then what you do, unfortunately my little videos aren't working, so it kind of looks like this, with a big bulk of cement proximally. And the point of it is, so you start off and you just coat the cement on a small hemiarthroplastic component, but you'll see at the bottom, there's supposed to be a video, but you see at the bottom, there's a big wad of cement proximally. And what you do is, maybe that will work, hang on. Oh no, I'll go on. So what happens is when you put that big wad of cement in and push it down, as you're pistoning it in and out, it conforms to the variable anatomy, the little jigsaw type anatomy of the proximal humerus, and fits in really nicely. And I wish a video was shown, because as it is pistoned in and out, you can see how nicely it fits into the proximal humerus. So it creates it's not cemented in, but it's a nice press fit, which means it doesn't rattle around in the humerus. So that's what it looks like when it's in. You can see how nicely it fits around that proximal humerus. Now, and that's a X-ray from their paper that shows what it looks like with that big bulk of cement proximally. And their results were interesting. They had 14 patients they used a functional spacer for. They were given a functional spacer and 6 weeks of antibiotics, and 9 of 14 did not elect to proceed with the second stage. And of those 9, no prolonged antibiotics were given, no residual infection in a minimum of 12 months, 89% satisfied, and they had not great function, obviously, but not too bad, and didn't have any loosening of the prosthesis. That's a case of mine. So this guy was just exactly the sort of person that might be good for this. He was a terrible candidate, really. He had type 1 diabetes, he had a history of lymphoma, he had bad heart disease, he had renal failure, he had ICU admission for a week after doing this operation. I thought he was going to die. And so he's not a guy we want to be ideally doing multi-stage revisions on. And so he had a functional spacer in, and he's about 4 or 5 months down the line and has no residual sign of infection. We still do have him on some oral antibiotics. We're just debating about whether we're going to stop that now. So surgical technique for this, same sort of thing, meticulous debridement, antibiotic cement, same deal, I think, in this or any one-stage revision. You know, close up after the debridement and then start again with a new prep. And consider, you saw a metal head there, but obviously the issue is getting a biofilm on it. And that's the problem with this technique. But if we use a ceramic or a pyrocarbon head, we do know that biofilm is less adherent to those things, so that may be a good option, and rifampicin might be very helpful for this. So I think that is a reasonable option. Nothing is perfect. I'd be very interested to hear what everyone in the audience has to say about their experience in managing infections. Obviously, it's a very difficult subject. And what happens if they say, I'm really unhappy with this, I need something more done? Well, obviously, you then decide whether you just go to a 2-stage. And it's interesting hearing the hip and knee guys, because they just laugh about us. They sort of say, well, just do a 2-stage. Just take it out, put a new one in, end of story, you know. But we know that doesn't always work, so that's when you may want to consider a 3-stage. Thank you very much.
Any questions for Terry at all about infection?
No.
Yeah, Steve?
Terry, do you see a role in arthroscopic debridement and specimen collection?
Well, yes. But the trouble is that already we're talking about massive contamination rates potentially. So, I mean, I must admit I have done it, and I've always used a cannula in doing it. So putting in a cannula and trying to take specimens from around the prosthesis, you know, in that interface. But it is hard. It is tricky to do it really well. So, you know, but yeah, it's certainly a good option for sure.
I just want to get a comment from Dr. Ross or Professor Ross. That 3% that North Shore sort of were talking about, Mark was talking about a particular process that they followed. Can you just elaborate a little bit more on that?
Yeah, I think it's a really interesting talk, Terry. The only thing I have issue with is your statement that it's hard to get clean cultures, because most places now have an Oxford tray, which is a separate tray with 6 sets of forceps and 6 scissors and 6 pots for specimens. And so it's actually quite easy to reproduce what the North Shore guys did. And that's what we do, and I think the false positive rate drops precipitously. And the problem with all the literature that you quoted is that they haven't religiously followed the Oxford protocol. So, I mean, I as I'm sure it looks like you actually cut and pasted one of my WhatsApp messages there about 3-stage. But I think if you diminish your false positives and use an Oxford protocol to ensure that your cultures are more accurate, then I think you can justify doing that. The other thing I always say is that the tendency to default to a more complex set of revision procedures is determined by the complexity of the reconstruction you're going to do. So if you don't need to use a custom implant or an allograft or something else, you can probably take the risk of doing a 1-stage revision. But it's actually very difficult to plan a complex reconstruction in a single stage. It's almost impossible. So I tend to default more to a multi-stage revision when I know that I've got to use allograft or custom implants.
Well, I did mention that based on what you told me before, actually. You know, when you've got a custom one, you certainly don't want to put it in an infected environment, take that risk.
A question for you, Phil, in relation to spaces. Not everyone's got experience with spaces. Obviously, there's moulded spaces that have been available, and there's been manufactured surgeon spaces. Is there a sort of a process or a better option for those sorts of things, Phil?
What do you mean by better options, sorry?
Is a moulded space better than a manufactured surgeon space in relation to function outcomes for patients? Terry talked about function being a problem for patients.
Well, I've used a lot of surgeon-made spaces, and the advantage is that they're bipolar, they're round, they're easy to make, you don't have to order them. And I've got a lot of patients that retain those because they have reasonable function. They're better than the pre-made or the ones you make yourself in the moulds, because they're sort of unipolar, articulating with the patient. As well, the ones that look, the cement moulded ones that look like a prosthesis tend to rattle around in the humerus, which is what Terry said, and or they break easier for me, and I get a higher rate of patients accepting them as a long-term solution. Yeah.
Do you like to use a bigger head or a smaller head? Some of those moulded ones are quite big sometimes, and they look like they don't fit very well.
But it's as big as they need to be.
Mm.
Yeah, to fit in there and to be stable enough.
Do you think you get much of a problem with instability in an infection? Aren't they always really stiff and hardly move at all? No, you can. You've seen them. Okay.
Oh yeah.
That's not
Well,
good.
I've had a couple dislocate of balls that I've put in. Not one of the pre-molded ones, but yeah, and the space in itself isn't inherently stable because you've often lost all the soft tissue.
Just one of the things when I was revising an implant for infection, I've just used a reverse mould of the current implant in a cement block and then just fashioned it back into the mould that I placed back in. Just an easy way to get a nice smooth surface.
Any other questions? One final question that I suppose you and I have talked about is blessings. Obviously, what have you sort of found out about blessings particularly?
Well, yes, there's a lot of research now about that. So basically, all of the chemicals that we use apart from betadine definitely show a cytotoxic concentration at any bacterial cytal level. Hydrogen peroxide particularly, it's 10 times greater concentration at a bacterial cytal level than is cytotoxic. So in other words, there is no magic window for hydrogen peroxide. There does appear to be for betadine, and that magic window seems to be 0.1 to 0.3%. So that's a 0.1 to 0.3% solution of povidone iodine, which, given the fact that betadine is 10% povidone iodine, that's a 1 in 100 to 1 in 30 dilution of that. And that's a little narrow window. And even then, it's a little bit cytotoxic and not that bactericidal. So it's not a perfect solution by any means at all. But I definitely think the evidence would suggest that if you're using concentrations outside that window, you're probably in a little bit of trouble. And there is papers that back that up. So the famous paper that looked at about 1,000 cases of hip replacement done before and then after using betadine. He used a 17.5 mils of betadine in 500 mils of normal saline, which equaled a 0.35% solution, and had good results with that. So, yeah. And WHO now recommended dilute betadine solution with some reservations.
Okay, Dr. Parsons.
Thank you. Maybe he's trying to tune in by the sounds of it. Hello. Okay, we're making up some great time so everyone can get home when they want to. Next, we have Dr. Moby Parsons. He practices knee, hip, and shoulder in Portsmouth, New Hampshire. He's a member of the Exactech design team, the navigation team. He trained at the University of Pittsburgh, where he performed a research fellowship in shoulder surgery. His clinical research on tendon transfers won the Neer Award. Dr. Parsons received fellowship training at the University of Washington and University of New South Wales. He's the founding member of the New England Shoulder and Elbow Surgeons and a regional leader in shoulder surgery. We really appreciate his time now. It's 5 o'clock or 5:30 in the morning where he is, and he's going to present a little bit on biomechanics and a lot about the future of arthroplasty in relation to navigation and the future of artificial intelligence and that social media aspect that I talked about. So I'd like everyone to welcome Dr. Moby Parsons to the Exactech User Group Brisbane. Thank you.
Thanks very much for the opportunity to present this stuff. Moby Parsons here from Portsmouth, New Hampshire. Just a little bit about my background. I had the wonderful opportunity to spend 6 months in Australia back in 2003, 2004 with Professor Sonneman and Jeff Hughes. That lower left-hand corner was my bus stop. So every morning when I got up to take the bus to the hospital, I got to look at that. So it was pretty tough leaving there. My daughters were 2 and 3 years old when we were there. So quite fond memories of having the kids down there. And my wife was pregnant with my son, who's now 17 years old. So when New Year's Day rolled around, Jeff said, he said, it's like they try to blow up downtown Sydney when they light the fireworks off the bridge. And that was a picture I captured from our neighborhood on New Year's. So great times down there, and looking forward to getting back there someday. So as mentioned, I've been using Exactech now pretty exclusively for about 9 years, and I've had the privilege of working on several of the projects, including the GPS project, the OrthoSensor project, and now Predict Plus, which is the artificial intelligence project. We'll go through each of these as we go. So just a little geography. That's Washington, D.C. there, New York City, Boston, and my practice is just about an hour north of Boston in New Hampshire, in the region we call New England, which is the Northeast United States. So about 12 inches of snow on the ground that came in yesterday. So pretty much the dead of winter up here. So we'll start off talking about reverse shoulder replacement. I was actually fortunate to see one of these in Australia before it was approved in the United States. And then when I started practicing in 2004, it wasn't long before we got our hands on the reverse shoulder arthroplasty. And at that time, it was for the 70-plus-year-old person with cuff tear arthropathy and pseudoparalysis. But as we know, the indications for this today have widened dramatically to a variety of different shoulder pathologies that we take care of now. And the incidence of reverse shoulder replacement has really skyrocketed in the last couple of years. And so if you look at registry data, starting in around 2014 timeframe, reverses surpassed anatomics in terms of the number being performed and the frequency of performing them. And the vast majority of surgeons now, when surveyed in the American Shoulder and Elbow Surgeons, which is really an international group, about 35% of surgeons report doing 70% reverses, 30% anatomics. And data from the Australian registry just last year shows that about 80% of shoulder arthroplasty in Australia is now reverse shoulder arthroplasty. So this has really taken over the market. And there's a lot of clinical scenarios that we encounter when we're doing reverse shoulder replacements that involve different pathology, what the status of any remaining rotator cuff is, whether they've had prior surgery, and all these things can affect soft tissue tension. And so we need solutions that can optimize the reconstruction for each one of these scenarios that we may deal with. And the one that I think has increased the most is the cuff intact arthritic shoulder that has severe glenoid wear. So this is now becoming sort of our go-to in these cases of the cuff intact arthritic shoulder. So much so that now the majority of reverses performed, and this is again data from the Australian registry, 46% of them are now performed for plain old osteoarthritis, and cuff tear arthropathy is now the second most popular indication. In women now, 20% of reverses are performed for fracture. So the fracture indication has really taken off quite a bit in the last couple of years. And there's a lot of systems on the market now. So this is actually a slide from about 5 years ago. And at that time, there was 29 different systems on the market. And now there's probably even more. And each one of these has different features in terms of implant options and biomechanics. And so you really have to know your system and how your system is going to allow you to address these different clinical scenarios that we encounter in everyday practice. There's a basic classification system that was put out by the Exactech group back in about 2013, and basically what this entails three different main design classifications. The traditional Grammont is a medialized glenoid, so the center of rotation is about at the glenoid face here, and a medialized humerus where the axis of the humeral shaft is fairly in line with the deepest part of the socket. Lateralized glenosphere was popularized by the Frankel group, and here the center of rotation is offset laterally to the face of the glenoid, and it's still an inlay type of humeral design. And then the Exactech design is a medialized glenosphere like the traditional Grammont style, but a lateralized onlay humeral prosthesis where there's an offset between the deepest portion of the socket and the axis of the humeral shaft here. And so this is the Exactech design here, medial glenoid lateral humerus. If you look at the market share increase, I think it speaks to the advantages of this design. So again, this is Australian registry data showing that the Equinox system has had the highest level of growth over the past 5 years, especially, and I think that speaks to the success of the design. So I'm just going to go through the top 10 reasons that I love this system and kind of prefer this system over all others at present. And these are not really in any specific order. So take that for what it's worth. Number one, I think that the medialized center of rotation is the one that best improves the deltoid moment arm. And because the deltoid is the one muscle that we know is the main driver of this prosthesis, the more that you can optimize the function of the deltoid, theoretically, that's better. It also respects Grammont's original design criteria, which is that the center of rotation must be at or within the glenoid neck, and it must be medialized and distalized. So you can see as you move the center of rotation from lateral to medial here, you recruit a larger portion of the deltoid fibers to help drive the reverse shoulder replacement. And so we've done studies on this now, looking at the impact of lateralization and medialization on the deltoid moment arm. And so in a traditional shoulder here, where the center of rotation is the center of the head here, you can see the moment arm of the deltoid is fairly small. And again, with the lateralized glenosphere design, because this center of rotation is lateralized, that actually reduces the abduction moment arm of the deltoid. With the Grammont style, by medializing it, you improve that, but because it's a medialized humerus, your deltoid gets flattened out. And with the lateralized humeral design, with the medialized glenoid, you sort of optimize everything by maximizing the length of this moment arm by having the deltoid be able to wrap around this lateralized humerus here. The lateralized design also helps maximize any residual rotator cuff tension. And again, we talked about the stabilizing function of the deltoid wrap here. So the more that you can wrap the deltoid around the tuberosity, this is helpful for stabilization of the implant by creating a compressive force that helps keep these implants together, particularly when there's not a lot of remaining cuff left. But many of these cases, you will have intact teres minor and sometimes intact infraspinatus, particularly in the cuff intact arthritic shoulder with severe wear. Being able to lateralize optimizes the soft tissue tension in any remaining external rotator. So the ability to regain active external rotation after a reverse is important, and we know that people that can't regain that are less satisfied with their outcome. And so this lateralized humeral design is the one that is going to closely reapproximate the cuff tension, which should improve the function of active external rotation. This was the original platform system. And I think we all know from our tribulations nowadays the importance of being able to just quickly switch between primary and reverse shoulders. This is a case of mine. This is a lady with rheumatoid arthritis that I did a total shoulder on. This is an ingrowth humeral prosthesis that has ingrowth that goes down to about here. You can see how osteopenic her bone is. and here's her glenoid component here that cut out of her glenoid. And so when I went to revise her, I had to take this stem out. And you can imagine in bone like that, the difficulty. You can see the stress shielding that she's got here, and then the kind of bone loss that you wind up with when you have to do your revision surgery. So, you know, Joe Zuckerman, who's the godfather of this prosthesis, has said there's really no role for a non-platform system in today's shoulder arthroplasty environment, and Christian Gerber has echoed similar thoughts. And here's another, you know, case where same type of implant, taking out a well-fixed ingrowth implant with a lot of stress shielding around the bone here, and having to contend with that. This is an allograft prosthesis composite that I had to do just to basically restore some bone to regain stability. And so this is not a good day in the operating room, although that x-ray looks kind of cool. This is really not an optimal solution. And so a platform stem is really just something that is critical nowadays. The design of the base plate, I think, is also optimized in this system. The curved back of the base plate converts shear forces to compressive forces, which can reduce the risk of glenoid failure. And it also allows you to ream less bone. So some of the systems that have a flat back surface, you have to remove more bone to ream the glenoid to a flat surface. And this offset cage, having the cage offset from on the base plate, allows you to achieve an inferior position to lower the risk of scapular notching, but to keep your fixation peg in the best portion of the glenoid vault. And again, having a nice array of screw holes there to take advantage of the bone. Strong initial fixation with this press fit cage, and there's good evidence that you get long-term biologic fixation. If you've ever had to take one of these things out, you know that it gets good bone through growth into the cage. And then having these variable axis screws that can be locked again allows you to get maximum screw purchase. The onlay design, I think, number one, it speaks to the platform nature of the system. It also allows us to make an anatomic neck cut that we're used to making in a primary shoulder arthroplasty. And if you look at the nature of an onlay versus an inlay, you preserve a lot more proximal humeral bone than having to ream out the metaphysis of the proximal humerus, where you can really thin that tuberosity bone. So from a bone preservation standpoint, having a traditional type of stem and neck cut, I think, is beneficial. And then if you look at the actual angle, this is about a 135-ish neck cut here, but the angle of the articulation is about 145 degrees, which is just kind of a nice sweet spot in the market. So the traditional ground, this was a 155 degree. The DJO lateralized Frankel design is a 135, and the 145 is sort of a nice sweet spot in between. And people have done studies on this, looking at range of motion, finding that this really is probably the best compromise for range of motion, being able to maintain improved external rotation and extension range of motion without sacrificing forward elevation. So again, a nice humeral design. Augments, I think, are really key nowadays, and we'll talk about this with preoperative planning, but having an array of implants that can deal with glenoid bone loss, I think, is critical. We know from our CT studies now and from our preoperative planning that glenoid erosion is quite frequent, and we deal with that a lot. And having implants that can correct erosion without having to remove bone or use bone graft, I think, is critical to preserving bone, maximizing backside contact, getting good initial fixation. This was a paper that Iannotti just recently published in the most recent JSES, so I just read this about 2 days ago, basically showing that particularly in cases where you have advanced glenoid wear, whether it's primary osteoarthritis or whether it's a cuff tear arthropathy situation, augmented glenoids can better correct pathologic retroversion and restore the joint line better than traditional standard implants. Number 7, glenosphere offset options are also really helpful in terms of soft tissue tensioning in these cases. And so having a +4 offset glenosphere, I think, is a nice feature. There's times where you don't necessarily want to have to increase the diameter of the glenosphere. And so being able to increase the lateral offset can help with tensioning and improve the deltoid wrap without having to overly distalize and overstretch your deltoid. So I think having an array of glenosphere sizing options is also a great feature. And this is important because instability remains the #1 complication of reverse shoulder replacement. And again, this is a graph from the Australian registry last year. And so having all these tools like offset glenospheres, having a humeral offset, augmented glenoid base plate, these are all ways that we can contend with instability when we do these cases. Preoperative planning, I think, is becoming kind of a gold standard in shoulder arthroplasty now, and Exactech has been doing this for quite some time, so we have quite a bit of experience, and we'll go through some of the new iterations of the software a little bit later in the talk. But just being able to quantitate the correction and plan this out in advance to make sure that you're minimizing bone loss, maximizing backside contact, getting the cage in the best part of the vault bone, minimizing scapular notching, and being able to see all this stuff in advance of the case, I think is now just becoming invaluable. Number 9, the GPS is just a tool that if you haven't adopted it, it's really a game changer. Being able to navigate these preoperative plans, particularly in cases of glenoid wear, and being able to see exactly where your drill bit is in the bone when you're putting your reverse screws in, it's just such a great tool to know exactly where you are in the case with the 3-dimensional view. And again, I think most of us that have adopted this technology and use it most of the time now can't imagine doing cases without it anymore. And finally, we now have the ability to capture and digitize the implant position. So we can correlate where we put the implant relative to our preoperative plan. And going forward, we'll be able to use this data to correlate with implant longevity and clinical outcomes and feed this into a machine learning algorithm. So in the future, the software may be able to tell us what the optimal plan is for each individual patient. So more on that to come. So that's a little background on the biomechanics and why I like this system. And we're going to move now to talking about some of the active intelligence solutions that Exactech is developing. And this stuff is really, really exciting. You know, taking patients through a total shoulder replacement is really kind of a journey for both the surgeon and the patient. It starts preoperatively, you know, educating patients, helping them set expectations for what they can achieve after surgery, kind of shepherding them through the preoperative process, and then planning the case, performing the surgery, selecting the implants, and then the postoperative, you know, navigating these patients through their rehab and tracking their clinical outcomes over time. So there's a lot that goes on when we take care of these patients. It's not like these little trigger finger releases where you can do the surgery and you never have to see the patient again. You know, these patients, we get to know them over years and years as we follow them. And so it's really a journey of care. And so implant companies are really moving away from just traditional providers of equipment and disposables, but to now working through this entire journey with surgeons and patients. And to be competitive in the future, implant companies are going to have to provide more than implants. They're going to have to provide solutions that deal with this whole journey of care. So Exactech is in the process of developing a whole ecosystem called Active Intelligence that's going to give us tools to help this journey of care. And these are going to be personalized tools that we can customize for our practices, easily implemented, cost-effective, designed to save time and effort, and also enhance the patient's experience. So quickly, we'll talk about GPS. This is I have a love affair with this technology, and I've been really lucky to be on the design team, working with great engineers and other surgeons to kind of bring this to market over time. Ionati was probably the first to recognize the value of CT-based planning, and there's been quite a bit of research showing that 3D CT scans are much more accurate than 2D X-rays or 2D CT scans in defining glenoid morphology and pathologic wear, which we now know is quite frequent in these cases. And then if you look at surgeons' ability, even in very expert hands, surgeons do not do a very good job of achieving a neutrally placed glenoid. So if you come up with a preoperative plan and then you have surgeons try to execute that plan with freehand instruments, you can see the scatter here. People, even great surgeons, can be all over the place in terms of their error, and the average error is up to 10 degrees, but you can see there's cases out to the 30-degree error range. And so the goal really is to try to tighten this cluster of points here using technology to make sure that we can accurately put these implants in. And we now have, again, a huge portfolio of implant options that we can combine with our CT-based plan in order to make sure that we're achieving all these goals of correcting version, getting good backside contact, making sure that our fixation is in good bone. And I would argue that this is now becoming a relative gold standard. And this is particularly important when you have cases like this where you have these extremely narrow glenoid vaults, and you basically have one shot to get this thing right. And if you can't see where that vault is relative to the face of the glenoid, you're really just guessing. And so, having technology that can allow you to put this kind of, thread the needle here with your implant is really game changing. What we know from various studies that have been done is that people who use preoperative planning tend to use more augments. And I think what this speaks to is how CT-based planning has allowed us to better recognize pathologic wear. It's quite frequent. So in large series that we've done where we've looked at this, the average glenoid retroversion, if you just take 100 cases, is probably about -13. And so, obviously there's a big spectrum, but cases where you may think there's not that much glenoid wear oftentimes have erosion that can be 13, 14, 15 degrees. And leaving implants in that degree of retroversion, does it matter? I don't think we know. I don't think we have long enough term follow-up. But if you can correct that using augmented glenoid implants, I think probably there's value to that. And so what we know is when we use this preoperative planning software, we use a lot more augments. And being able again to see this intraoperatively is really helpful, particularly when using augmented implants. If you're trying to do this with a K-wire and with a drill guide, it's very difficult to know exactly how you should position your hand for reaming so that the ream surface of your glenoid is in line with the central drill hole. When you use GPS, you don't have to worry about any of that. It tells you exactly where you're going and how to position your hand so that you can achieve all these important things to make sure that your implant is solidly anchored in the bone. And this is seeing really great adoption across the world. So despite COVID, this is a technology that continues to grow to the point where we've now done over 12,000 GPS cases around the world, and up to a third of shoulders are now navigated. And so this is really caught on, I think, with good reason. And this number of publications is now probably closer to 10, and there's several more in the pipeline, showing Exactech's commitment to pushing this forward and proving the value of this. So we did a validation study basically looking at what the accuracy of this is, showing that with navigation and preoperative planning, you can get that error rate down to about 1.5 degrees, plus or minus 1.5 degrees and 1 millimeter, much more accurate than conventional instruments, even more accurate than patient-specific instrumentation. A lot of good studies, and this is all studies that have come out of Australia. Mark Haber's group showing that with GPS navigation, your ability to achieve neutral alignment for inclination inversion is much improved, and up to 40% of cases, no discernible difference over the preoperative plan. Studies also showing that the learning curve is quite short, and so Alan Wang did a study showing that just after about 8 cases, it becomes relatively time neutral. So this is not a time suck in the operating room, and many people, once you kind of memorize these steps of registration and tracker placement, and your operative team kind of gets this down, many people would argue that it actually reduces time, particularly when you're using augmented glenoids. The time it saves you in terms of figuring out the reaming and the central drill hole and all that, it actually probably saves you time after you've gone through the initial learning curve. So really doesn't add a lot in terms of disrupting the workflow in the operating room. And to me, this is where the real value is, seeing where these screws are in bone. Otherwise, it can be a guess, and particularly in these cases where you have bone loss or revision cases, being able to position these screws for maximum length and fixation, I think, is really game changing. And so, again, Mark Haber's group did a nice study showing that with GPS, you can get significantly longer screws. Upcoming versions, and there's going to be several new iterations of the software that are coming out in the future. GPS 1.7 is going to allow us to have basically implant rotation, so we can dial in the rotation of the implant as we impact this. That's helpful just in aligning your holes where your best bone is based on your preoperative plan, but also knowing that as you impact it, you're in line with your central hole, so you're not off axis during your impaction. And this is something that patient-specific instrumentation will not be able to do. And again, being able to digitize that final implant position so that you can correlate that with patient outcomes over time. So that's just kind of showing as you impact it, you kind of have a target for what your trajectory is right there. This is kind of what the workflow looks like. So you're going through your conventional drilling your pilot hole, reaming, and then navigating the cage hole, and then adding these steps of digitizing where your central drill is so that you know your drill is seated for appropriate depth when you're going to impact it. Being able to rotationally clock your implant placement before you impact it, and then being able to basically guide the impaction and digitize the final position of the base plate after you've seated it. Later this year, we'll be able to do this with anatomic shoulder replacement. Again, I think for the cage glenoid, it's critical to not be off axis when you impact that thing. You want to make sure you're on axis, and being able to make sure that your central hole is completely bottomed out so that you can seat that implant to maximize backside contact is really key. We'll be able to navigate the rotation in the peripheral holes with some of the next software iterations that are coming out in the future. The 1.9 version will be compatible with the Ergo instruments, which are going to be rolled out later in time. We're just now beginning to get our hands on these instruments in the U.S., and that rollout will sort of continue across the world. I think probably the neatest part of this will be how this version of the software will allow the GPS system to tell you what color the screw is. So it'll basically be able to figure out the depth of the drill relative to the bone, and then tell you what the color of the screw will be without having to use a drill guide to do that. And there's going to be reduced error messages on registration and depth. And so these are all future iterations. And then probably the most exciting is the addition of humeral sided planning, which again is going to come over the next year or so. And so it's essentially going to take the interface that we're familiar with now on the glenoid side and just add some features to it. One is that it's going to support a multi-plane view, so you'll be able to have two different planes up at the same time to look at where your implant is relative to the glenoid bone. And then adding the addition of humeral sided planning for the reverse. That'll include the resection angle, the version of the cut, the level of the neck resection. And then again, you can play around with the inserts here, the tray thickness, stem thickness to plan all that. And based on how you change the level of the cut here, this humeral sided planning will allow you to determine which range of motion goals you've achieved on the humeral side. Same thing on anatomic. You'll be able to determine relative to the head cut here, the clocking of the implant on the face, picking your replicator plate, and the size of the humeral head that'll cover this cut surface optimally, and also the clock face here to determine the rotation so that you can optimize the coverage of the cut surface there. Go through quick range of motion analysis after the humeral sided planning, and you'll be able to compare different plans at the same time to figure out which one is going to give you better range of motion and impingement free range of motion. So this is showing a comparison between two different plans so that you can pick the plan that's going to potentially give you the best range of motion. So all that stuff is coming down the pike in the future. So that's going to be really, really exciting. VeraSense is a project I've also had the privilege of working on. This is an implantable trial force sensor for reverse shoulder replacement, and it's made by a company called OrthoSensor. VeraSense is the name of the trial implant for the reverse, and Exactech has worked with OrthoSensor to develop this. The reason this is important is because we still don't really have any good quantitative information on the tension and reverse shoulder replacement. So right now this is fairly qualitative, and so even if you go to national meetings and you got people like John Sperling up on the panel and these people that are thought leaders in shoulder arthroplasty, if you ask them how tight should you put a reverse shoulder replacement, and people kind of shrug their shoulders and don't really have a good scientific answer for it. And we kind of base these things on Gestalt now, using difficulty of trial reduction, whether you can shuck it, taking it through a range of motion, pull out liftoff test, etc. And really, we're just using our gut feeling about this right now, which is fairly unstructured. And so the goal of this project is to try to get some more quantitative data so that we can objectively determine this based on evidence and not on gut feeling. And the reason this is important is because some of the top complications of reverse shoulder arthroplasty may be related to the forces across the joint and the tension in the soft tissue. And these include instability, dislocation, and acromial stress fractures. And so we're hoping that the information that these trials can provide will sort of be a surrogate for determining the risk for some of these complications. And I think that there's a huge opportunity here. So we're still very much in a data gathering stage with this, and we're still learning what this technology can do, but I think it's fairly exciting to be able to have the opportunity to get this quantitative data. And basically, this is a disposable trial. It comes in 38 and 42 millimeters and 0 and plus 2.5. And you can implant this when you have your trial stem and glenosphere in place, take the shoulder through a range of motion, and it'll interface by Bluetooth with this tablet in the operating room that'll show you in real time as you take the shoulder through a range of motion what the forces across the joint are and where that force is located on the trial sensor. So this is a video taken, and this is actually Sven Goebel in Australia. He put the first one of these in the world, and you can see this is showing as he takes it through a range of motion where the force is concentrated on the trial insert and the force magnitude here as it goes through a range of motion. And there's a series of range of motions that you can take this through, measuring rotation, extension, and forward elevation, as well as cross body, to see what the forces are throughout those different ranges of motion. Some of the preliminary cadaver work that we've done on this has shown that kind of in the mid-range of motion, there's this dwell region where the forces are relatively low. And as you get towards the end range of motion, the soft tissue tension causes the loads to go up fairly appreciably. There's also kind of what we call the tail region. So the dwell region is this mid-range where the forces are low. The tail region is where the soft tissue tension increases, causing higher forces across the joint. Again, we don't really know what all these numbers mean yet, but we're learning. We also did a study where we kind of correlated subjective tightness to load. So if you put these things in what feels like it's really tight, the loads go up quite a bit in the tail region. And if you put them in what feels pretty loose, the loads remain pretty low in the tail region. But interestingly, in the dwell region, the loads are not that much different between tight and loose configurations. And again, this is just a graph showing that the dwell region loads stay pretty low regardless of how tight it is, but the tail region loads go up a lot. And so as we increase the tightness in the construct, the forces across the joint at the end range of motion go up quite a bit. And so as time goes by and we do more of these cases, we're going to gather more information on what these numbers in this range here mean. When is the force too much, and when is it too little? So that's all stuff that we're going to learn with time. But we think that there's going to be a sweet spot between mobility and stability. And having these trial inserts is going to help determine where that target zone is to optimize the soft tissue in these cases to reduce things like stress, pain, stress fractures, and instability. And so kudos to Sven for doing the first one of these in the world in Perth. Moving on, Predict Plus this is a tool that this is available right now, also being developed kind of as we speak, but an exciting project that Exactech is putting forward to try to create clinical decision support tools for patients and surgeons. The idea is that we all learn from our own individual experience, but for individual surgeons, we tend to learn from our best and our worst cases, not from the hundreds of cases we do that are right around the top of the bell curve. And so if you can harness the collective experience of a lot of people, you can get a lot of valuable information. And so this is really a predictive analytic machine learning project, which is using historical data to try to predict the likelihood of future outcomes. And machine learning is everywhere around us all day, every day. So banks use this to try to figure out when somebody's committing bank fraud and stealing your credit card number. Netflix has recommendation engines that tell you what movies you might like to watch based on what you've watched before. Google can listen to you and start, filling in the rest of your search before you even type it in. It's almost like it's reading your mind. Chat bots, this all uses artificial intelligence. Recommendation engines, Amazon tells you what you might like based on historical purchases. And so it's around us all day, every day, and it's coming to healthcare fairly rapidly. The most popular applications to date have been in radiology for things like tumor scanning. But the reason that this is important in shoulder arthroplasty is we now have this clinical database with a huge amount of data in it. But conventional statistical techniques are not very good at capturing important relationships in these huge data sets. If you just do a scatter plot and then a regression analysis on data like this, you may not learn anything, but if you feed this into a machine learning algorithm with huge data sets, you might find relationships that conventional statistics can't tell you. And Exactech has really been ahead of the curve on this, developing technologies. And there's historical precedent for this too. There's other groups out there that are working on similar things in shoulder arthroplasty. The concept is you take your data, you create an algorithm, and that algorithm will spit out predicted outcomes based on that historical data. And the algorithm will learn through a feedback process as you iterate and dump more data into it to become more accurate over time. Exactech has this amazing database with 35 centers around the world. It's got over 10,000 arthroplasties in it at present. And so the idea is to take this huge data set, and eventually we'll be able to feed into this imaging data from the GPS, CT scan data, Hounsfield units, bone density, muscle quality, muscle cross-sectional area, fatty atrophy, all these things. And all this data will be able to be fed through algorithms to help teach us quite a bit before we do these cases. Right now, there's 291 inputs in the data that Exactech collects, and they've done studies to basically be able to boil 291 down to 19 inputs to keep it simple for the surgeon. So Exactech has shown that there's a minimal feature set of 19 inputs that leads to a predictive accuracy of about 90%, which is really, really quite good. This is just a video of what this looks like. So you can actually go to this site now. I have this kind of bookmarked at the top of my my Google thing here, and so you can click on this, and you can go through this Predict Plus. You can do this with patients right in your office, where you can take them through this, or you can actually send this to patients by an email link before their office visit and have them fill this out. You can add additional questions if you want to get an ASES or a constant score. There's additional questions that you can check off here. Add the diagnosis, whether or not you want to do an anatomic or reverse, or you can get comparative information if you want to decide which type of arthroplasty would be best for your patient. You can check both of those. And then essentially you're just going to walk through quickly, entering demographic information, prior surgery, dominant shoulder, comorbidities, and then range of motion inputs. It's all pretty easy, moves along pretty quickly. And again, you can have your medical assistant do this. You can do this on a tablet. You can do it on your computer in the room. And the workflow of this is something that we're actively working on. So we have design team meetings frequently, and as we use this more in our clinical scenarios, we're trying to ensure that this is a seamless workflow for people in their office so that it doesn't disrupt your clinic day. And again, you don't have to add these additional questions to get the ASES score. It may be more academic, but for patients that like that information, you have the option to put these added questions about pain and about some daily function stuff. These are the ASES questions here. And again, you can send a link to your patient's email before their clinic visit or before their pre-op visit, if you want to have them fill this out before they come in, just to minimize some of the time that this could take in the course of a busy office day. And essentially, after you've entered all this information, what it will do is it will churn this data, and it will spit out your results. It'll generate your predicted outcome for these patients based on those inputs that you put in preoperatively. So it'll tell you here what their expected pain relief will be, comparing anatomic to reverse, what their global shoulder function will be. Again, you can see the difference between anatomic and reverse and what their expected range of motion will be 2 years after shoulder arthroplasty, which is about when people top out in terms of their outcome. It'll also show you complication risks based on patients of similar age and gender. And then it'll show you these longitudinal graphs over time so that you can show people what their expected improvement will be over the course of time. Again, showing around 2 years is when people achieve their relative max, and you can do this for various range of motion parameters, abduction, forward elevation, rotation, but also pain and ASES scores. So that can be very helpful, I think, in terms of guiding patients about expectations. And so the goal here is to basically provide evidence-based clinical decision support tool for the patient and the surgeon so that you can tell them what their expected range of motion and pain relief may be, and also what potential complication risk is. And it's also going to show you what the driving factors are behind outcomes and complications. And so if you have risk factors, you may be able to mitigate some of these things in advance to lower patients' complication risks. And again, this is patient-specific data. There's also a general feeling amongst ASES members, and again, this is a graph from a survey that we did of ASES members about a year ago, that the ultimate goal of machine learning is going to be to help us plan these cases. And so once we can get this imaging data fed into these cases and some of the clinical data based on implant placement, in the future, these predictive algorithms may be able to tell us exactly how we should plan these cases, what implants we should use, what type of arthroplasty we should be doing in these cases to maximize outcome. And it'll all be based on thousands of cases and real data, so it's going to be backed up by clinical evidence. Mover, we'll move on to what Mover is a state-of-the-art healthcare platform. Mover is actually a startup company that Exactech has purchased. This is technology that is kind of in development right now, so this isn't really available for widespread use, but it's coming down the pike. And essentially the idea here is to have a smartphone-based platform that will allow you to communicate with patients through kind of a text messaging chatbot. So you can correspond with them about preoperative questions, postoperative questions, therapy questions, etc. It's going to be all smartphone based. Patients can have an app on their side that they can enter information about therapy progress, etc. And the surgeon can have a dashboard about how these patients are doing postoperatively. So if you have somebody that who may not be achieving their range of motion goals, you can kind of get an alert on that and potentially have the capacity to intervene before they run into trouble. Ultimately, the goal is to have wearables that patients can put on that will track range of motion and feed it into this app over time. This is starting off in the knee replacement, but the goal is to have this available for the shoulders. I think what COVID taught us is that these kind of telehealth options and being able to communicate with patients in a forum other than the office is highly possible, and it's also in a way very nice for people that don't necessarily want to come into the office. It also allows the surgeon to kind of optimize your schedule. So if you have a clinic that's full of post-ops, you're not seeing new patients and booking new cases. And so just in terms of the efficiency of the office, if you can root out some of these unnecessary follow-ups, it's satisfying for the patient because they don't have to come in, and it may allow you to kind of optimize your practice and deal with some unnecessary office visits and keep your phone traffic to a minimum by using, text messaging. And so this is something that your physician assistants or extenders or your medical assistants in your office can also have access to communicate with your patients before and after surgery. And you can customize this to your practice so that you can, if you have therapy protocols that you want to be able to push to your patients, this is all customizable. If you have preoperative instructions or wound care instructions or whatever, all that stuff you'll be able to feed into your own personal Mover app that you can push to patients. Again, the goal is to take these wearables that are currently available for the knee and allow these to measure shoulder range of motion over time. So you'll be able to have, both the patient and the surgeon will be able to track range of motion progress over time as patients are going through their recovery process. All based on a smartphone app. This can also collect patient-reported outcome measures, and you can push video messages and the like. So it's going to be pretty neat. And basically, it's designed to do all these things, reduce follow-ups in the post-op period, free up time to see new patients in the office, reduce incoming phone calls, et cetera, et cetera. And lastly, we'll talk about Chime. Chime is a smartphone app. This is available now, so you can actually download this now. And I've used this several times already. And this is basically like a collaborative communication tool. So if you're like me, I'm in a private practice with just one other partner. He's a hip and knee surgeon. And so if I have a difficult shoulder case, I don't have anybody in my office that I can bounce that case off of. And I really don't have anybody in my hospital or my immediate surrounding practice area, that I can bounce difficult cases off of. And so Chime effectively gives you the ability to communicate with other people about cases using a very easy to use app on your phone. It's available for Android and iPhone users, and it's basically just an exchange platform. And so it provides the ability to do case-based discussions, and you can also poll people if you wanted to figure out how many people would do anatomic versus reverse, etc. You can create polls. Exact will be able to push us news about upcoming developments through the app like this. And just like any like social media application, you can set it to give you alerts. So if you post a case with a question, it'll alert you when people have responded to your case, so that you can quickly check it. This is a little bit what it looks like. If you want to enter a case, it basically syncs with your photo library, so you can take some photographs of X-rays or a patient or whatever it is. It'll alert you if it's not compliant with patient privacy laws, and that may differ by country, but obviously, like in the United States, you have to be very careful about not posting patient information that allows you to crop that stuff out and kind of make the picture look pretty, and then enter case details about it, and then post it online, and then other people can pull up your case and provide feedback on what they would do. And so it's kind of a way of instantly having your case reviewed by a bunch of experts who use this implant system and have familiarity with challenging cases. So I've recently posted 2 cases on here that I wanted feedback on. It's just really, really helpful. And then you can turn around and tell your patients, hey, I got feedback from 5 or 6 other surgeons. This is what we're going to do. And it kind of eases their mind knowing that it's like they're getting a second and third opinion for free without having to travel anywhere. And so again, this is available today. You guys can download this today, and I would strongly recommend it, because I think the more people posting cases on here, we can all learn from each other. So pretty exciting stuff. So that's pretty much a wrap on my talk. I think the take-home point here is that Exact is really at the forefront of moving beyond a company that just sells implants. And it's really giving us a wider array of smart solutions that involve, technology to help us be better surgeons, data to help have evidence-based guidelines to help guide our care, and better communication with our patients and fellow surgeons to learn and really help shepherd our patients, through this journey of care. So a lot of exciting stuff coming down the pike in the future, and hopefully the near future. And that's it. I'm always happy to communicate with anybody. This is my email here. Feel free to reach out anytime by email. Also, if anybody wants access to any of these slides, I'm happy to share slides with anybody. If anybody's giving talks or community education lectures or anything like that, just reach out anytime, and we can share information. Thank you guys very much for the opportunity to present this stuff to you.
Dr. Parsons, that's a very informative talk, and the future looks very bright. So thank you very much for joining us. Round of applause for Dr. Parsons. You can go and do some exercise or have some breakfast. Thank you.
Sounds good.
Thank you. Bye-bye.
See ya.
Righto. So we've made up some great time there. We've just got one thing left to do. I asked
said he couldn't do much for her. And she's come to me now, the young buck on the coast, looking for some answers. And so you can see she's got a varus malunion there, but the concern there is that the proximal epiphyseal regions has displaced from the shaft. And so if we go to the CT, obviously we get a significant amount more information. And I guess most of the information I wanted to present was actually there on the axial CT. And so some initial thoughts that I had here is, could I use a short stem prosthesis? I was planning for reverse. She's got a deficient cuff. And then other thoughts were that of using a trauma prosthesis or performing an osteotomy. Sorry, this isn't scrolling through. And so what you sort of can appreciate here is that the shaft of the humerus is quite significantly displaced from that of the epiphyseal region. And so to get a stem down that actually would prove quite difficult. And so I was off to the opinion practically of the room, because I wanted to preserve what is left of her infraspinatus on that proximal head, and so that she can restore some external rotation post this operation. Has anyone got any ideas? Yeah, hang on, I'll bring that up. Yeah, just here, I'll show you. So that was one of my key concerns, just as a smoker. But you can see how displaced that that malunion is. So yeah, I could 3D print that humerus.
Dr. Thomas?
Yeah, I found the 3D printing really helped with this. I've got a presentation. I'll email it to you, Robert. It's got some good pictures on it. But it went very well until the woman overdosed on verapamil 2 weeks post-op and arrested 3 times. Got defibrillated, and it still didn't dislocate. So she's still alive with a prosthesis in.
Phil?
Can you put that into the machine, the Exactech machine, and see what it says?
So Robbo, we know that reverse works with a 4-part fracture, and you can stick the tuberosities back on where you want and get them to heal. So why not just osteotomize it, create a 4-part fracture, and do the reverse, and print it in practice if you feel the need?
Why wouldn't you leave the proximal intact?
Well, because there's so much offset.
Well, yeah, well, when you cut the neck.
Oh, you might leave that, assuming when you get in there that the cuff's attached to the bit that's on the shaft, you'd leave it. But you'll find subscaps attached to the bit that's displaced.
I just see there's an advantage to cutting the neck, leaving the proximal part intact, and shifting everything and putting it intact, rather than cutting everything off and having to reposition.
Well, you won't be able to reposition the subscap. That's the only problem. I suppose since we're in an Exactech forum, we don't have to worry about the subscap.
We worry about it still.
Mark, I'm a big believer in preserving subscap. That's probably because I came through your stable and Dr. Duke's stable. And so that was my plan, is I was going to preserve subscap, and then I was going to perform an osteotomy and treat it exactly as such, in terms of putting a fracture stem down and then reattaching the tuberosities to the fracture stem. In fact, I didn't think I needed to disturb that proximal bone block terribly much, aside from create a fracture site at the previous malunion, because I'd just chisel out where that fracture stem would go and then reattach the tuberosities accordingly. But I didn't know if anyone had experience in using a shorter stem or any other weird and wonderful thoughts.
Okay. Well, that wraps up the night. I know everyone's a bit tired now. You can tell by everyone's a little bit dreary-eyed. So thanks very much for coming. I hope you've learnt something or got something out of it. And we'll see you next time. Thank you. The Gold Coast people, your transfer is coming now and should be downstairs in the next 5 minutes. Robbo and Luke, your lift home is down there as well now.